This conference will now be recorded.
జ్యోతి ప్రకాష్ హలో
వినిపిస్తుందాం.
సార్ వచ్చారు.
Good morning to everyone. Today's topic is approach to chest pain. You will encounter the same symptom in your daily life once or twice. I am saying this because chest pain is not only cardiac origin. It may be either gastrointestinal origin or musculoskeletal origin, and many more like pulmonary origin or vascular origin. Basically, we encounter the most dangerous forms of chest pain through cardiac origin. So we consider mainly the cardiac origin of chest pain. I think at this stage you should be able to differentiate the chest pain based upon its site, character, and the radiation. You should learn how to differentiate the chest pain based upon presentation. I think at the end of this session you will be able to see various types of various causes of chest pain, and you will be able to localize the cause. Acute chest pain is one of the most common reasons for presentation to the emergency department, accounting for approximately 7 million emergency department visits annually in the United States. The presentation suggests acute coronary syndrome, but after diagnostic evaluation, only 15 to 25% of patients with acute chest pain actually have acute coronary syndrome, which I have discussed earlier. Only 15 to 25 patients will be with cardiac origin. However, the diagnosis of acute coronary syndrome is missed in approximately 2% of patients. The most common cause of chest pain, the patient presenting to the emergency department is gastrointestinal, 42%. It may be either due to peptic ulcers or drug-induced or esophageal spasms, gastritic symptoms. And second cause is ischemic heart disease, which lead into acute coronary syndromes. Next is chest wall syndromes. It is musculoskeletal. Reed syndrome, pancostitis, you can see in these syndromes. Next is pericarditis, pleuritis. Next is pulmonary embolism, which is rare complication. Lung cancer, aortic aneurysm, aortic stenosis, and herpes zoster. These are the main causes for acute chest pain. In acute chest pain, the most dreaded complication, the most presentation of myocardial ischemia is chest pain. You will encounter these types of angina, stable angina, unstable angina, and MI. In other cardiopulmonary causes, you will see pericarditis, aortic dissection, pulmonary embolism, pulmonary hypertension, and in lung, pulmonary tracheobronchitis, spontaneous pneumothorax, and in GI causes, which we have discussed earlier, and in musculoskeletal, costochondritis, and cervical rib. Infections such as herpes zoster and panic disorders psychologically. And in myocardial ischemia, the classic manifestation of ischemia is angina. The Heberden initially who described angina as a sense of strangling and anxiety. Chest discomfort characteristic of myocardial ischemia is typically described as aching, heavy chest pressure, squeezing. It is basically the most common presentation of MI is of squeezing type of chest pain. The patient patient will describe as the chest pain is squeezing and crushing type. Can anybody tell me what is this sign you can see here? Can anybody answer? What is this sign?
Levine sign, sir.
Very good.
Levine sign, sir.
Very good. Very good. The Levine sign, which describes the patient squeezing substernal central chest discomfort. It's a typical cardiac origin sign. The typical presentation of angina associates with radiation to either shoulder or to both arms or to back, interscapular region, root of the neck, jaw, tooth, and epigastrium. And I have a doubt. What is the most common radiated upper limb in MI? Can anyone answer? What is the most common upper limb? Either it is right upper limb or left upper limb. To where the radiation is most common in MI?
Left.
Can
Left,
anyone
sir.
answer?
Left, sir.
Can anyone answer?
Left.
Left? Is it left?
Left shoulder.
No, it's right shoulder. Basically, in movies we will see the same presentation. In movies they will show the left hand only. Like in Atharanti Daredi you will see na. It's not left hand. The pain radiating to the right hand is the most common. Most common and most specific. Angina is rarely localized below the umbilicus. It is called as abdominal angina. Myocardial ischemic discomfort does not radiate to trapezius muscles. That radiation pattern is more typical in pericarditis. Anginal equivalents. Anginal equivalents are symptoms of myocardial ischemia other than angina. They are shortness of breath, nausea, easy fatigability, and faintness. More common in women, elderly persons, and diabetics. In diabetic patients, we will see this autonomic neuropathy and peripheral neuropathy as they lack the pain stimulus. In diabetic neuropathy, the most common neuropathy you will see in diabetic neuropathy, distal symmetrical polyneuropathy, in which the small muscle fibers are affected, leading to loss of pain and temperature. So in diabetic patients, the pain stimulus will not be easily identified. So this with this anginal equivalents like shortness of breath, nausea. In our emergency department, we can see many diabetic patients present to our emergency department with shortness of breath and nausea and vomiting. In typical inferior wall MI, the patient can present with nausea, vomiting, and diarrhea. In typical inferior wall MI. And this type of MI presenting in diabetic patients is called silent MI. The angina pectoris, discomfort in the chest and or adjacent areas. Adjacent areas means already we have discussed that back of interscapular region, arm, jaw, shoulder, usually but not always with MI. Typical angina, substernal chest discomfort with the following features. The characteristic squeezing and heaviness and crushing type we have already discussed. This is typical angina with associated duration provoked by exerted or emotional stress, relieved by rest and nitroglycerin. These 2 points are very important to confirm angina. Anginal pain will be aggravated on exertion and relieved on rest and nitrates. This is typical angina presentation. And with the typical angina, Chest pain of variable character, not of squeezing and pressing type. Duration will be varied, not predicted or influenced by physical activity. We have discussed it should be relieved with rest in typical angina. And in postprandial angina, angina precipitated by meals, and in nocturnal angina occur within 1 to 2 hours after assuming recumbent position. Next, Heberden's angina is very important. It is also called as chronic stable angina, is also called as Heberden's angina. Chest pain is related to relatively fixed amount of effort, pain relieves on rest. And Prinzmetal's angina, this is very important. Prinzmetal's angina is also called as vasospastic angina. It occurs due to coronary vasospasm. It mimics typical angina. Unstable angina, absence of ECG and enzymatic elevations. Enzymatic elevations means this troponin, myoglobin, creatine kinase, CKMB, all this you will not elevated in unstable angina. Typical MI, pain lasts for more than 20 minutes. Ischemic heart disease is the most common atherosclerotic plaque you can see. Stable ischemia. 1 minute. In ischemic heart disease, the most underlying pathology lies with dyslipidemia, that is formation of atherosclerotic plaque in the coronary arteries. This leads to ischemic heart disease, narrowing of the lumen of the coronary, leading to ischemia followed by infarction. Stable ischemic heart disease usually results from the gradual atherosclerotic narrowing, which already discussed. Unstable ischemic heart disease occurs when rupture or erosion of one or more atherosclerotic lesions triggering thrombosis. The atherosclerotic plaque which formed in the vessel of the coronary artery will be displaced leading to unstable ischemic heart, unstable angina. Unstable ischemic heart is classified as unstable angina when there is no detectable myocardial injury and as non-ST elevated MI. The mechanism of cardiac pain, it will be discussed easily. One second. Yes, the ischemic episode which excites the local chemo and mechanosensitive receptors, it leads to release of adenosine, bradykinin and histamine and serotonin, and it in turn stimulation of cardiac sympathetic efferent fibers and cardiac plexus, and in turn stimulates sympathetic ganglia, spinal ganglia and thalamus, where it is called a sensory relay station, leading to pain. This A gamma and C nociceptive fibers are stimulated. Chest pain characteristic with increased probability MI. This slide is very important because a patient presented to the emergency department with chest pain should immediately identify him whether it is due to cardiac origin or due to other cause, because we will have a golden period to treat MI. It may be either due to right coronary artery occlusion or left ascending anterior descending artery occlusion or left circumflex artery occlusion. We should first initially we will have a golden period to treat the patient with MI. In that golden period only we can do thrombolysis with alteplase, tenecteplase, streptokinase, urokinase, all these thrombolytics. In our hospital we will use urokinase, which we will give less than 4 to 6 hours. If the patient presents with MI within 4 to 6 hours of golden period, we will use this thrombolytic therapy. So identification of a patient with chest pain is of cardiac origin is very important. So these presentations are very important in this slide. It radiation to right arm or shoulder, which I have discussed this point earlier. Radiation to both arms associated with exertion. Radiation to left arm associated with diaphoresis. Diaphoresis means sweating and palpitations associated with nausea or vomiting. worsen than previous angina or similar to previous MI. And in some patients, the patients will describe as గుండె బరువుగా ఉందండి అని చెప్తారు మనకి. ఎమర్జెన్సీ డిపార్ట్మెంట్కి వచ్చి గుండె బరువుగా ఉందండి, ఒక 2 గంటల నుంచి బాగా బరువుగా ఉందని చెప్తారు. Then also you should consider the cardiac origin chest pain. These are the most likely causes MI if the patient presenting with these features. These are atypical features, most likely not due to MI. Inframemory location or in middle or lower abdominal region. Basically, it is of most likely epigastric pain, gastritic pain, or due to peptic ulcer pain, and described as pleuritic pain, sharp knife-like. It is of due to pleural origin, pleuritis or pleural effusion. Pain that may be localized at the tip of one finger, particularly over the left ventricular apex. That is basically either due to costochondritis. Localized pain. Localized pain means it is of mainly musculoskeletal origin. Pain reproduced with movement or palpation of the chest wall or arms. Pain that radiating into lower extremities. Constant pain that persists for many hours. Very brief episodes of pain that last a few seconds or less. Typically, we have seen MI pain lasts more than 20 minutes. We have seen in this slide. You can observe MI pain may last more than 20 minutes. But here varies. In pericardial disease, the visceral surface of most of the parietal surface of the pericardium is insensitive to the pain. Therefore, no infectious cause of pericarditis usually usually less likely to cause pain. In contrast, infectious pericarditis, most common TB, almost always involves surrounding pleura, leading to pain while breathing or coughing. Radiation to trapezial ridge is characteristic of pericardial pain. It is very typical. Radiating to trapezius muscle region. Swallowing may induce the pain because of the proximity of esophagus to the posterior artery. It is of pericardial origin, pericarditis or something, or infective version of pericarditis. Pain may be radiated to shoulders and central diaphragmatic region due to irritation of phrenic nerve. Involvement of pleural surface of lateral diaphragm can lead to pain in the upper abdomen. Pericarditis occasionally causes a steady crushing substernal pain that resembles that of acute MI. Many chest pains mimics MI, but we should be able to differentiate the exact cause of cardiac origin or non-cardiac origin. This is stress-related cardiomyopathy, Takotsubo cardiomyopathy. It is very important entity because it also mimics MI. It also mimics MI. It occurs in very young age. In athletes, we can see this type of cardiomyopathy in athletes. Takotsubo cardiomyopathy, sudden onset chest pain, shortness of breath, triggered by emotional or physical stress, mimic acute MI. ECG shows ST elevations and elevated biomarkers. These all findings we can see in MI. So it is very important to differentiate Takotsubo cardiomyopathy with MI. In coronary angiography, we can easily identify this Takotsubo or MI, as ECG shows same ST elevations and elevated biomarkers. Aortic emergencies are very important because coarctation of aorta or aortic dissection. Coarctation of aorta or aortic dissection are very important emergency situations in which you should treat immediately. If not, we can lose the patient. Aortic emergencies. I am stressing this topic because we will have very less time if it is a case of aortic dissection. The patient will have ripping type of pain. The typical aortic emergency chest pain is intrascapular origin. The pain occurs in the interscapular regions between the two scapulas. Aortic dissection occurs more commonly in elastic fiber disorders like Marfan's Ehlers-Danlos syndrome, bicuspid aortic valve, proximal dissection in pregnancies, distal dissection in the hypertension. Aortic dissection is very important. And vascular disease, pulmonary embolism. Now at present, pulmonary embolism is of very important in this COVID situation, because in this COVID is basically a hypercoagulable state. You can observe in many patients affected with COVID have elevated D-dimer levels. Elevated D-dimer levels are very much sensitive to detect pulmonary embolism. This in last 1 to 2 months, we have seen 3 cases of pulmonary embolism in our COVID emergency COVID ICUs. COVID related pulmonary embolisms. Massive pulmonary emboli tend to cause severe and persistent substernal pain attributed to distance from pulmonary artery. Smaller emboli that leads to pulmonary infarction can cause lateral pleuritic chest pain because of involvement of pleural surface of lung adjacent to resultant pulmonary infarction. We can identify this pulmonary embolism on ECG also. Basically, the gold standard test to identify the pulmonary embolism is CT pulmonary angiography. CTPA is gold standard for identifying pulmonary embolism, but in ECG, the most common finding seen in pulmonary embolism is sinus tachycardia. We will see the sinus tachycardia first, and next S1Q3T3 pattern. You may hear this MCQ. In pulmonary embolism, we will see the S1Q3T3 pattern in ECG. And very important third finding is T-wave inversions in leads V1 to V4. These 3 ECG findings are very specific to pulmonary embolism. And the earliest finding is already discussed, sinus tachycardia. And in pulmonary hypertension, this pulmonary hypertension is of also very important because in right heart failure, that is in core pulmonary, we will see this pulmonary hypertension. Chest pain is similar to that of angina pectoris, presumably because of right heart hypertrophy and ischemia. It is associated with dyspnea and signs of pulmonary hypertension. You can easily identify this pulmonary hypertension clinically. The patient presents with raised JVP, ascites, pedal edema, and shortness of breath. If the patient presents with these 4 symptoms, you can shortly diagnose pulmonary hypertension without any 2D echo finding, without any 2D echo measurement of MSVP. And other pulmonary conditions are tracheobronchitis. It also leads to chest pain. Spontaneous pneumothorax. It also leads to chest pain. Sudden onset pain with dyspnea. And pleuritis. We have already discussed the sharp pain, pleuritic pain. And pneumonia. And the very important and most common chest pain causing entity, gastrointestinal conditions, esophageal reflux, GERD. The many patients will present with chest pain to emergency department with this complaint only. GERD. They present with the typical patient description of the symptom is, he will describe as అన్నం తిన్నానండి, తిన్న 1 hour కి బాగా తేన్పులు తిన్నది వెనక్కి వస్తున్నట్టుగా వచ్చి బాగా గుండె నొప్పిగా వచ్చిందండి అని చెప్తారు. The presence with burning substernal epigastric discomfort aggravated by large meal, postprandial recumbency, alcohol and aspirin, and relieved by antacid and sitting upright position. And it also most common in obese individuals, GERD. And the most important MI mimic. This esophageal spasm is also called as MI mimic. It typically presents with classical MI features, MI findings. Squeezing, chest discomfort similar to that of angina, 22 to 30 minutes in duration. The same squeezing type of pain seen in MI, the same duration of chest pain you will see in esophageal spasm, and the same thing, it will be relieved by nitrates. So it should be differentiated with MI. Esophageal spasm should be differentiated with MI. Peptic ulcer, the most common presentation. Chest pain occurs 60 to 90 minutes after meals. It is of burning pain and epigastric region, relieved with antacids. And in gallbladder disease, colicky pain, you will see this right epigastric, right hypochondriac pain, colicky type of pain, may be followed by a meal. And pancreatitis, prolonged intense aching epigastric and substernal pain may radiate to back. This is very typical. Pancreatic pain will be radiating to back. In acute pancreatitis, many alcoholic patients will present with pain radiating to back. And musculoskeletal, it is very important MCQ. Teat syndrome, costochondritis, Teat syndrome, sudden onset of intense fleeting pain reproduced by pressure over affected joint, sometimes swollen, tender, warm over joint. And the next thing is cervical disc disease, sudden onset of fleeting pain, aching type may include numbness produced with movement of neck. And in trauma, you can see this flail chest and everything. An infectious herpes zoster, prolonged burning pain and dermatomal distribution. This vesicular rash is of very important. In the dermatome, this vesicular rash will be distributed in dermatomal distribution. And psychological panic disorders, chest tightness or aching often accompanied by dyspnea lasting 30 minutes or more, unrelated to exertion or movement. Situational factors may precipitate symptoms. The history of panic attacks and depressions are most common. Acute potentially life-threatening conditions. These 6 entities are very emergency to treat. Acute coronary syndrome, MI, we have already discussed about this golden period giving thrombolytics, and we have already discussed aortic dissection and coagulation of aorta. Acute aortic syndromes, these are also very emergency to treat. Pulmonary embolism, we have seen S1Q3 T3 pattern, sinus tachycardia, T wave inversions in V1 to V4. Tension pneumothorax, it is also very important. Patient present with hypotension. Pericarditis with tamponade, it is a very serious complication. Pericarditis with tamponade, we will see the Beck's triad. Can anyone say Beck's triad? What is Beck's triad? What is Beck's triad? BECKS, Beck's triad, TRIAD, Beck's triad. Can anyone? What is Beck's triad? Hypotension, prolonged pulse rate, and engorged chest veins is called Beck's triad, and it is seen in cardiac tamponade and pericarditis. And esophageal rupture. These 6 are very important life-threatening complications with chest pain. Characterize the chest pain using the following components. Now we will see the quality, location, radiation, duration, and time course. Based upon all these entities, we will find out the type of chest pain, the quality, which is already discussed, squeezing and strangling and pressure type of pain, myocardial MI, the chest tightness, a band across the chest, like a band, heaviness, esophageal spasm and reflex, and pulmonary hypertension, deep, heavy aching pain, visceral pain, maybe either due to herpes zoster, indigestion, a need to belch. Many patients of MI may present with peptic ulcer disease, and many peptic ulcer disease patients may present with MI. They both have the same presentations. So in emergency room, if a patient presented with more symptoms like acute peptic ulcer disease, to rule out MI, you should compulsorily go for ECG. serial ECGs 1 hour apart, irrespective of his condition. If he presents with acute peptic ulcer disease also, you should confirm it with MI, as both the presentations are of same. The severe tearing pain, which is also already seen, aortic dissection, stabbing, sharp knife-like pain, pleuritis, pulmonary embolism, and psychogenic pain. Dull persistent ache lasting hours or days, localized to cardiac apex. It is of psychogenic origin, and its localization substernal or retrosternal we had seen in myocardial infarction, and if it is involved joints or superficial structures, we will see with musculoskeletal costochondritis chest wall syndrome. And radiation is a very important entity in chest pain to differentiate the causes. In MI, we have already seen with arms, shoulder, radiating to back, jaw, neck. In MI, pain radiating to lower jaw, neck, and teeth. MI. It can also radiate to all these structures also. Does pain radiate into interscapular region, which has already described aortic dissection, very emergency to treat. Pericarditis, esophageal disease, peptic ulcer, and MI. Does pain radiate to epigastrium? Yes, those are peptic ulcer, pancreatitis, esophageal disease, and gallbladder disease. Depending upon duration, we have already discussed. MI pain, angina pectoris pain, and ischemic pain will last for up to 20 seconds, 20 minutes, and if a pain is of less than 15 seconds, it's of musculoskeletal or hiatus hernia. It is of more than 20 minutes of MI, pulmonary disorders, and musculoskeletal disorders. Myocardial ischemia and discomfort usually lasts for minutes, is exacerbated by activity and mitigated by rest, which is already described. Pain that is fleeting and pain that is constant in intensity for a prolonged period is unlikely to represent MI. The precipitating factors, which is already described, exertion is a precipitating factor for MI. Warm-up angina, in which some patients experience relief of angina as they continue at the same or even a greater level of exertion without symptoms. Emotional stress may precipitate angina. Eating meals also may precipitate angina, peptic ulcer. Lying down or bending after the meals, reflex disease, which is already described. Bending or moving the neck, cervical disease. The pain increased with cough or respiration, pulmonary embolism, pericarditis, and pleuritis. Changes in body position, pericarditis and pancreatitis. And the relieving factors, association of relieving factors. Already we have seen with rest and nitrates, MI pain and esophageal spasm. Sitting up and leaning forward, very specific for pericarditis and pancreatitis. The patient in the emergency room can be seen with sitting and leaning forward, pericarditis and pancreatitis. Relieved with antacids, peptic ulcer, and esophagitis. Holding the breath at deep expiration is pleuritis. And the associated symptoms, which I have already described, nausea and vomiting, diaphoresis and dyspnea. Syncopal attack with MI. And the water crash, which occur due to reflex. Hemoptysis typically presents in pulmonary embolism and pneumonia. And the fever, infective origin, like pericarditis and pleuritis and pneumonia. And coming to examination part, first we have to see the vitals. And systemic examination. In ECG, we have already discussed. In MI, there will be ST elevated MI and non-ST elevated MI. Basically, non-ST elevated MI is seen mainly in the ischemic area. In infarcted region, we will see the ST elevated MI. In infarcted, there will be symmetrical, tall, peaked, and widened T waves. This point is very, very important. The T waves will be symmetrical, tall, and peaked and widened. ST elevation you will be seen, and non-ST elevation, ST depression with symmetrical peak T wave version is seen. And in unstable angina, symmetrical T wave version with or without ST segment depression is seen. In Prinzmetal's angina, which is described earlier as vasospastic angina, we will see the tall and widened T waves which occurs due to coronary vasospasm and ST segment elevation, and it is all of transient changes. Chronic stable angina, we can see ST depression more than 1 mm, T wave inversion and U wave inversion in lead V5 and V6. In pulmonary embolism, we have seen this S1 Q3 T3 pattern and V1 V4 and sense tachycardia. In 2D echo, 2D echo is diagnostic modality for MI because you will see the regional wall movement abnormality in 2D echo in MI. You can easily see the lateral wall or anterior wall or posterior wall MI in MI. The wall movement and wall mobility will be decreased. It is called as regional wall motion abnormality, RWMA. Chest radiography, pneumonia, you can easily see the consolidations and air bronchograms. And the pneumothorax, very important. 3 signs are there in the chest radiograph. Those are Westmark sign, Hampton's hump, Pallas sign. These 3 signs I will show in the radiograph in next slides. These 3 signs are very important of pneumothorax. And in pulmonary edema, you can easily see the batwing appearance and blunting of postcochondral margins. And in aortic dissection, you can easily see the tearing of the aorta and widening of mediastinum. Pericarditis, you can see, which I have discussed, Hampton's hump and Westermarck's sign. Dilation of pulmonary vessels proximal to embolism, along with collapse of distal vessels, often with a sharp cutoff, which can be seen in pneumothorax and pulmonary embolism. Which can be seen in pneumomediastinum and pulmonary embolism. This is Hampton's hump. This is Westermarck's sign, dilatation of pulmonary vessels proximal to the embolism. A homogeneous wedge-shaped consolidation in the lung periphery, Hampton's hump. These 3 signs are very important for your MCQ purpose. And cardiac biomarkers for an MI, the most important and most sensitive cardiac biomarker is troponin I and troponin T. The first marker to elevate is myoglobin, and the marker of reinfarction is CKMB. These 3 points are very important. D-dimer, we have already discussed in pulmonary embolism, it will be elevated, and in heart failure, the natriuretic peptide will be elevated. Multiple clinical algorithms have been developed to aid in decision making during the evaluation disposition of patients with acute non-traumatic chest pain. Such decision aids are used more commonly to identify patients with low clinical probability of ACS, who are candidates either for early propagated testing for ischemia, for discharge from emergency department. And today's take-home message is: many of our parents will have diabetes and hypertension. Most commonly, they will have type 2 diabetes. Of our patients is of elder age, so they will have type 2 diabetes most commonly. Diabetic screening and hypertensive screening should be done yearly once if they are controlled, if they are in normal range or controlled range, and if they are uncontrolled, you should go for 3 months monthly, 3 to 4 times of diabetic and hypertensive screening. Diabetic screening means you should go with diabetic fundus examination to rule out diabetic retinopathy, and to rule out diabetic nephropathy, we should go with serum creatinine levels and spot albumin creatinine ratio. It is a very important and sensitive marker for albuminuria and to detect early diabetic nephropathy. Many of the people that do not screen for diabetic nephropathy, and it will increase the morbidity and mortality of the patient with diabetes. Diabetic nephropathy should be screened if the sugars are not controlled, and you should also screen for diabetic neuropathy. You should go for filament test, monofilament test, and multifilament test, and nerve conduction studies if you have any peripheral neuropathy complaints. If a patient of diabetes, prolonged diabetes, uncontrolled diabetes have a complaint of tingling, numbness, and paresthesias. These three are very important: tingling, numbness, and paresthesias. The patient will definitely have peripheral neuropathy in diabetes. They should refer to a neurologist and go for treatment. These three symptoms are very important. అరికాలు మంటలు, అరికాలు తిమ్మిర్లు వస్తున్నాయని చెప్తా ఉంటారు మనకి. మన ఇంట్లో ముసలోళ్ళు కానీ మన పేరెంట్స్ కానీ అరికాలు మంటలు, అరికాలు తిమ్మిర్లు అని చెప్తారు. టింగ్లింగ్, నమ్నెస్, పారాస్థీషియస్. All these symptoms should be screened in our parents or in our relatives yearly once if they are controlled. If they are uncontrolled, should go for 3 monthly or 6 monthly tests. And the very important slide coming for MCQ purpose, heart score. We have already discussed about diagnostic aids. This is one of the diagnostic aid, heart score. It is history, ECG, age, risk factor, and troponin. In acute chest pain, if this is of high risk, it is typically of anginal pain or MI pain. And the other is North American chest pain rule, which has typical symptoms of ischemia, acute ischemic changes like ST elevation and T wave inversions, and age more than 50 years, known coronary artery disease, and troponin more than 99%. Thank you.